Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, you've taken me to new frontiers of medicine through our time together, and today new frontiers of pronunciation, because we're talking about Dupuytrens, which is spelt nothing like it sounds.
Well, this is named after a French surgeon, so however they pronounce it, you never know, they may even correct me, so yeah, I may be getting it wrong, but we're talking about Dupuytrens Contracture, but why don't we start off with a curse?
Oh, okay.
Yeah. So this, in the 16th century, was thought to be a curse. The Scottish Clan MacCrimmons. Now, no one knows how the curse came about. They thought either it was the curse by a widow whose son had been taken by the MacCrimmon clan, or it had been cursed by the curse had been put on a lady by the name of Anag, who had shared a secret with the rival clan. But the Scottish, as I'm sure you're well aware, play bagpipes.
Yes, they do.
And this had special significance in this instance. And what the curse was it was said that, well, they were not going to be able to play the bagpipes anymore. They were the official pipers, so to speak, of the MacLeod clan.
I'm beginning to like this curse.
And so they were the pipers, and it was said that they would be discharged of their duties and sent away.
Wow. And
so what happened was now, interesting enough, the bagpipes aren't actually originated from Scotland. It goes all the way back to ancient Egypt, and even Romans, and it seems to have come across from the Romans. And there's even an ancient coin of Nero playing the bagpipes.
I'm not sure many movie directors will be bold enough to be historically accurate in the film to have Nero playing the bagpipes while Rome burned.
But it's an interesting sight. It's probably prophetic at that time when the bagpipes are going down. But this was the 16th century, and the pipers. So this was obviously a very big part of the tradition and a big part of their identity. And the instrument was also used in like peace and war, and even then got to the point where it was seen as being played during a war. And it was sometimes even it even got banned at a certain point because it was only meant to be for war in those instances. So you never know, someone might be sharing your sentiment there. But it was said that this curse was that the MacLeod of Dunvegan, so the other clan, who were on the Isle of Skye, they would cease to have the MacCrimmons as part of their pipers, and they'd be sent away. And it started to happen that this curse was becoming true. And this was because the men of the MacCrimmons clan's hands became twisted and gnarled. And it was sort of resembled more of what they said as a claw, and it couldn't be released. So their hands started to twist up. So what happened was they were actually unable to play the bagpipes. They were stripped of their duties, and they were forced to leave the Isle of Skye. And if you can imagine what this curse is, if you get your fingers and curl over your little finger and ring finger pretty much into a sort of like a claw-like position down to all the way down to the palm, and can't release that, then that's what was actually happening to these Scotsmen.
So they're just rendered with just a thumb, a forefinger and a middle finger.
Yeah, so they could still use that to a point, but we'll discuss that a little bit further later. But that was kind of the happen, and sometimes it would happen on both hands.
Oh, gee.
And so these people were pretty much unable to release their hands at that point in time. And this is why it was called Curse of the MacCrimmon. And it had a few other names. And we call this Dupuytrens Contracture today. But the history goes much further back than the 16th century. In fact, we find the first real mention of this in ancient history in the first millennium BCE. And this is with the Thracians and Phrygians. Now, this was around ancient Greece and Turkey time. And the Thracians and Phrygians were polytheistic. And one of their gods was known as Zabios. He was a horseman, the Sky Father god. Now, we don't know a huge amount about this because the culture wasn't literate, so we don't have a huge amount of information. But we have it because they were taken over by Romans and Greeks, who always incorporated other gods into their own. And so what happened was, because they took them in, it showed dominion over your gods. So I was stronger than you. I took over your gods. I'd even take your icons or your idols, and I would have them. So I ruled your gods effectively.
Wow.
And so there's an artifact that you can see to this day, and it's called the Hand of Zabios. It's a bronze sculpture. Now, there's many of them about, but again, these were little figurines, and sometimes they were large. They would go into the houses of people to worship. And if you look at it, if you have the open hand, and again, bend your little finger and ring finger to the palm, that is the symbol of the Hand of Zabios. And so they would have often animals around the fingers or little figurines denoting different parts of clearly what they worshipped. And when we look at this, people have examined this and said, this actually looks like Dupuytrens Contracture. And that's thousands of years ago. And the interesting part about this is, just like what the Romans were doing, if you look at what this symbol, this looks almost like a symbol, it is actually the hand of benediction, Christian.
Yes, it is.
So
bless you, my son.
Exactly. And this is potentially one of the links that the early Christians may have actually taken on this symbol. Now, now you, as again, dominion over winning over another culture or another god. And so this hand of benediction. And if you look, there is an image of Pope Xylus from 256 to 258 AD on a gold glass at the Musea Sacro in the Vatican of him doing that symbol in the Vatican. And this is the classic kind of Dupuytrens Contracture image.
Yes. I'm going to quickly see if we can rename this biblical life.
Well, again, all of this links in. Imagine if this was if the symbol we see as the hand of benediction today is actually an old pagan symbol that the early Christians took over. And we now associate it almost with a sign of divinity. And yet some cultures would have seen that as a curse, just like the Scottish.
The Scots.
And so it is interesting to see that this has been with us for a very long time. And the problem is we actually don't know the cause. We know what's happening, and we will explain that later today with some of our guests. And we do know that there is a strong genetic link, ethnicity and sex, age and factors. And we do know that this is commonly associated with people who have Northern European ancestry. And so when we look at the affected patients, 68% of people have male relatives who are affected. So there's clearly a strong male. And again, that's why it comes back to the MacCrimmons, who were male pipers, would have been more affected, and that's why it was seen as a curse to them. And there's increased genetic links to the Netherlands, to the German, to the UK. So if we go back then, how do we find this in Scotland?
Yeah.
And this actually, the one main event that keeps on coming up is that in England, the 8th century, there's something called the Great Heathen Army. And this is when, now, England was accustomed at this time in the 8th century to men of the north coming to their shores and raiding. And they called themselves the Vikings. They were actually Danes or Danish. And England had been experiencing this since 787 CE. They would have, in the summertime, seasonal, they would come across, raid the shores, and they actually targeted monasteries and churches.
Oh.
And the reason why is because that was where the wealth was kept.
Of course.
And so that's why they were called heathens. Now this often, they would often be around, they would war, and what ended up happening was if they stayed around for a long time, they would actually be paid off. And because they were Danes, it was called Danegeld. So I would give you a tributary to go away, effectively, and they would leave. But this year in 865 was when the great heathen army landed. Now, it's hard to say because this is when myth sort of crosses over with history. Either 1,000 or 3,000 men came across, and they had no interest in leaving. And so they then went around for over 8 years warring all the way around England. And by the 10th century, 3 of England's 4 great kingdoms were held by these Vikings. And by that time, they had started to plough the land and they had started to settle. And so why do we know this? Is because the things such as Curse of the MacCrimmons or the Celtic Hand or Vikings disease was Dupuytren's contracture. So the genes came across, started affecting these people from this great heathen army. And that's how we found it in Scotland, is because they had come over from Northern Europe and raided and then settled, and their genes came into this. And so if we start to look at the medical history, though, there is the first documented case by the surgeon Felix Platter of Basel in 1614. And he had a patient, first documented case, of a stonemason.
A certain distinguished stoneworker rolling an immense stone so that the tendons of the left hand flew to the fingers, defining the ring and the little, were attracted to him, so that they loosened and, raised by the bonds by which they were restrained, brought 2 strings taut under the skin to a height, and contracted these 2 fingers, and being attracted, they remained ever after.
So Platter believed this was caused by tendons being pulled from their sheaths. And that was, again, the only really way that they could understand this was by examining cadavers with their pathology that was going on. And there was another surgeon in 1777, Surgeon Henry Klein Sr., who documented contractures and proposed the idea a little bit later on of palmar fasciotomy as a treatment. So this is putting cuts in the aponeuroses and seeing, well, that could release it. Sir Astley Cooper was a surgeon at Guy's Hospital who had an interest in this quote-unquote palmar aponeuroses. And in a lecture in 1805, he stated,
"In one subject, all the fingers were contracted, but upon cutting through the fascia, they were immediately extended."
And in his book, he wrote this:
"The fingers are sometimes contracted by a chronic inflammation of the theca and aponeurosis of the palm of the hand from the excessive action of the hand in the use of the hammer, the oar, ploughing, etc. When the theca is contracted, nothing should be attempted for the patient's relief. It's no operation or other means will succeed. But when the aponeurosis is the cause of the contraction and the contracted band is narrow, it may with advantage be divided, introduced through a very small wound in the integument. The finger is then extended and a splint is applied to preserve it in a straight position."
By this time, another person had become very interested in it, a French surgeon, Guillaume Dupuytren. And he was a French surgeon, and he had been collecting a whole bunch of patients who had had this condition. And in 1832, on the 5th of December, he gave his landmark lecture at the Hotel Dieu, where he presented 30 to 40 patients he had seen over 20 years. He called this condition rétraction permanente, which meant exactly what it sounds like. And some of the patients he presented, one was a 40-year-old coachman, another one was a wine merchant who obliged to sip often of wine. And what he proposed was that at this time, the treatment of this affected ring and little finger was useful to release it. And the joints were normal, so it wasn't a pathology of the entire hand. It was just of this aponeuroses. And he thought it was associated, but not always, with local trauma to the hand. And in a post-mortem, he described the contracture.
The skin having been removed along the entire surface of the palm and the fingers, the wrinkles and gathering that had offered before entirely disappeared. The dissection was continued. The professor discovered the palmar aponeurosis and noticed with astonishment that it was stretched, retracted, diminished in length. While trying to extend the fingers, M. Dupuytren saw clearly that the aponeurosis was undergoing a sort of tension. He cut the extensions that it sends on the sides of the fingers. Immediately, the contraction stopped. The fingers came back to the half-quarter of bending. The least effort brought back the phalanx to complete extension.
And so he attempted the first operation, and it was on the wine merchant. Now, this was in June 1831, so before the landmark presentation. So clearly, he wasn't just presenting patients as to say they've all got this disease. He was clearly saying they've got this disease, and here's how we treat it. And so this was the fasciotomy, the release of the ring finger and the little finger, which required a few more incisions. And they, at this point in time, had left the wounds open for pus to escape. So they thought pus was the normal part of an operation, which back then it probably was. But they thought that was part of the healing process. And so when they looked at it, the wounds healed, the stiffness resolved, and the patients were cured. This was considered an operational success. And this is why we know it today as Dupuytren's contracture.
Gee, I would be very tempted to share a bottle of wine with that wine merchant. Dr. Paul van Minnen is a plastic and reconstructive surgeon who studied medicine and received his PhD from Utrecht University in the Netherlands. Dr. van Minnen qualified in plastic surgery in the Netherlands before coming to Australia, where he completed 3 years of an advanced fellowship in reconstructive microsurgery, burns surgery, and hand and wrist surgery at the Royal Adelaide Hospital and Flinders Medical Centre. Dr. Paul van Minnen runs his own private practice in Adelaide. It's called Grip Surgery, and he's our guest today on This Medical Life. Welcome, Paul.
Thanks for having me. It's great to be here.
Yes, well, let's continue this dive into this topic by getting this on the table first. What are the typical classical presentations you might see for a patient with Dupuytren's contracture?
Yeah, thanks for asking. I see a lot of people with Dupuytren's disease arriving in my practice, and it's a huge variation on how people present. So as you're aware, Dupuytren's causes lumps and bumps in the palm, which can turn into cords and then cause contractures of fingers. Now, some people, they come for a different problem. Let's say a carpal tunnel syndrome, and you look at their hand and you see a little bump sitting in their hand. You go, have you ever noticed this? And they said, I wasn't really aware. That's the one extreme. And the other extreme is people who have very advanced contractures where the tips of their little and ring fingers are touching their palms and they can't open them. And so they'll have hygiene issues, keeping the skin clean in between and all those things. So there's a huge variation. But to answer your question, the very typical patient comes with a mild to moderate cord affecting usually the ring or little finger. That's causing some stiffness and discomfort. And then you look at their other hand and you find other little changes and to go with it. So that's your very typical one. Yeah.
So then looking at the progression, is there any way, because clearly with such a broad spectrum, is there any way to know who's going to advance very quickly or to actually have probably minimal disease throughout their life?
Yeah, you can't measure that. There's no classification you can do that, but you get a sixth sense for it. There's one rare occasion where a person would be affected by what they call a Dupuytren's diathesis, which is a combination of clinical factors that are going to be bad news. So if someone's got bilateral disease, is over 50, male, positive family history, European background, and has got the Garrod pads on the backs of the little lumps on the backs of their PRP joints. If they present, you know that it's going to be an uphill battle getting control. For your typical patient that we described before, there's not really a way to predict it. So you get a sixth sense. If people say, "Oh yeah, my uncle had it, my mom," and I'm 35 and I've got two fingers involved, it's bad news. But yes, it's you can't predict it in any other way.
Now, there's a bit of literature out there at just internet as well, saying that there could be things that help alleviate it. Is there anything such as massage or splinting or exercise that will prevent the progression of disease?
No, that's what my understanding is of the literature and the evidence, and also what I find in clinical practice. I think if there is any evidence available that I trust, it's the evidence that says there's no way to influence it. So no amount of stretching and massaging and splinting will influence how the Dupuytrens goes. It sort of makes sense as well, right? So let's say you have a fibroproliferative disorder of your palm. This is what this is. There's all these little myocytes and contractile collagen fibers that want to do their own thing. And I think if you put a splint on a hand overnight, it's not going to really help.
Could I ask the other side of Travis's question? He was talking about things that could alleviate. Are there any things that make this condition worse or aggravate it?
Yeah, there's been a lot of actual fun dialogue about that. There used to be the factors mostly talked about is alcohol use and vibrating tools. Like if people use a lot of vibrating tools, and let's say repetitive trauma to your hand. But as soon as these get pitched, someone else debunks it and says that's actually not true. Okay. What I find an interesting one is that when I was doing my training, it was about 15, 20 years ago, people were embarrassed because they thought it had a relationship with alcoholism, and people would say we didn't want to be associated with that. But the reason why people thought that, it is if you want to find, let's say you're in the 1980s and you want to find a Dupuytrens patient, if you go to your local pub and mix in with, a group of 10 middle-aged men having their drinks, you will find one with Dupuytren's disease. And so they say, oh, so there must be association between alcohol use and Dupuytren's, but that's not true. And the same is with the vibrating tools. There's lots of work cover research being done that sort of, negates that. Wow. that relationship. Yeah.
Well, actually, that touches on something else. Well, how common do you find Dupuytren's contracture then?
How common are they? Yes, they're very common. I think a recent study, 7% of the entire US population will have some degree of Dupuytren's disease. Wow. That's the latest number I've got. So 7. And 1/3 of those will eventually have a form of intervention for it. That's a huge number, and that's the US population. If you go to UK, Ireland, Scotland, Scandinavia, it's more than that. Like if you're Norwegian and 80 and you're a male, you probably will have Dupuytren's disease. There's a huge chance that that's what that is. Yeah.
So then, is there any useful tests to confirm the diagnosis, or is it just really obvious that someone's got it?
Yeah, it's clinical diagnosis. I don't see any need for any further investigations. If somebody presents with a nodule and you can touch it, you can feel it, you know what that is. If their history matches too, then you're 100% sure. If it's not quite a Dupuytren's nodule, if it doesn't feel the same, you might want to do an ultrasound scan to see if it's maybe a ganglion cyst or another sort of hand lump. But no, I think it's just clinical only. Paul,
in preparing for this, we came across the tabletop test. What's that?
Yes. Yes, it's the most useful thing to know about in Dupuytren's disease for the patient, the GP, and the surgeon. So the tabletop test is a test where you try to put your hand flat on the table. Just relax it down and just put your palm and your fingers all flat on the table. If you can easily do that,
Yep.
then there is no significant Dupuytren's contracture there. If the contracture is causing your tabletop test to become so that you can't easily get your hand flat, there's a bit of space between your palm and your fingers and the table, then there's a contracture developing, and that's considered a positive tabletop test. Now, it's good for the patient to know, because you can tell them, like, monitor it, like, there's a little nodule now, don't worry about it, do the tabletop test at home. If you start to hover over the table, then come and see me. And for GPs, it's good, because if a patient presents with a positive tabletop test, it's a good reason to refer to a surgeon.
I did that while you were talking, and I would hazard a guess that just about everyone listening to this podcast would have just done that as well.
Yeah, good.
Yeah. So then, looking at the treatment options available, what's the operative and non-operative treatment options available?
Yeah, so non-operative ones would be you can choose to do a cortisone injection or a glucocorticoid injection. In the early phases, when Dupuytren's nodules develop, they are more active and cellular, and they get a little bit tender. In those cases, if people are really bothered by it and it's too small to really excise, then you can choose to do a cortisone injection in the nodule to reduce the cellular activity and the tenderness. It doesn't really affect the progress or anything like that. It's more a comfort thing. But I do warn the patient that that particular injection is particularly painful, because it takes a lot of pressure to get that cortisone in that fibrous tissue. So it's not one I can't remember ever prescribing that in the last 5 years or so, but it is an option. Mm-hmm. Then you have the collagenase option, which is a Clostridium solution, which you can inject into the cord, and it actually dissolves the cord. So a patient visits the office on day one, you give him 1 or 2 injections in the cord, and then 2 days later you see them again. The cord is all soft, and then you push the finger, you manipulate the finger under a local anesthetic, and usually there's a spectacular crack or snap, and then the cord breaks and the hand straightens out. Now, that treatment was gaining a lot of traction a couple of years ago, and I set up a clinic back in the day at the Royal Hospital to do so, and we did quite a few, but then the TGA pulled the license for the Xiaflex. I think it's been reinstated, but a few years later, but I think it lost its momentum for a bit. It's not something I regularly do in my practice anymore. So that's option number 2. Other ones are you can do a needle aponeurotomy, which is using a small needle just to scratch the cord and then break it that way. But that's associated with lots of recurrence rates, because you don't really remove any tissue. Right. It's a good option for people who aren't fit for anything else. So if you don't want to submit a person to a general anesthetic or any form of surgical anesthetic, and they have a bad contracture with hygiene issues, for example, you can do a needle aponeurotomy and make it go a long way. But I think the gold standard still remains removal of the tissue, which is a selective fasciectomy, just removal of the Dupuytren's cords, and that's still my go-to treatment. So, sorry, that was a very long answer.
No, it's really interesting, because this is the important stuff for GPs to know. So,
in fact, it's gripping.
Yeah.
But
nice.
Looking at the treatment, when does someone need surgery then?
Yeah, that's a good one. So I think the rule of thumb, pun intended, is the positive tabletop test. I think that's, if somebody presents with a positive tabletop test and is motivated to do something about it, there's good grounds to propose a selective fasciectomy to do so. That's a bit of a rough guide. I think if you look at the official numbers, if somebody presents with a 30-degree contracture of the MCP joint or a 15-degree or more contracture of the PIP joint, those are good reasons to to say that an operation is indicated. The other option is that if a person presents with a painful nodule and they just want to get rid of it, I think that's also a good reason to just remove that. It's a 5-minute procedure at a small risk, but those are the accepted reasons to operate on them. So, roughly speaking, positive tabletop test is your guide, and people would qualify if they want to.
What's the recovery like for people who have had this operation before?
It varies, of course. If somebody has a minor one, it's usually quick. It's a day surgery procedure, and the sutures come out at 2 weeks. And the majority of people, so they go home with a soft bandage on their hand. They do have use of their other fingers. So let's say if a ring finger has the treatment, then I wrap up ring and little finger, and they got the other fingers free to move. Then day 3, the bandage comes down, and there's just hyperfixed tape on the suture lines. And with that, people can shower and drive and do most things. But at 2 weeks, then the sutures come out. The wound still needs a bit more healing at that stage. And I often advise people, like, if you want to do things like tennis or golf course or things like that with the operated hand, you probably have to wait 3 to 4 weeks for your typical case. And if someone has 3 rays or 4 rays involved and bad contractures, it might take 6 to 8 weeks for everything to settle down.
Yeah.
Now, what's the prognosis like for someone who has Dupuytren's contracture? Let's say they have an operation. Is there any way to work out recurrence or someone who's going to need further operations?
Yeah. Again, it varies a lot, of course. So if you have that person who's got multiple contractures and a bad family history, then I warn them that they will have a recurrence because you can just wait for it. The best numbers I can give you is that if you'd operate on 100 people today, like a varied degree of severity, and you see them all 5 years later, then 25% of those will have some form of recurrence. And that could be just a minor nodule or a very bad contracture that occurred, within 6 months after the operation. So a 75% disease-free 5-year interval you could sort of expect for most. But of course, it depends on how bad of a disease they've got.
Paul, thank you for taking us through this. Just before we finish, we'd like to ask if there's any final advice or tips for general practitioners, this time obviously regarding Dupuytrens.
Yes, I think the main take-home message is that the tabletop test is extremely useful. If a person has a little lump, like a nodule, and is not too concerned, there's not really a reason to refer. You can tell these people that, keep an eye on it, do the tabletop test at home, and if you notice that something's progressing, then come and see me again. I think that's a very useful tool. It's easy, it's quick, and it's quite reliable. Yes, I think, bring the tabletop test to your practice. I think that's a good way to do it.
That sounds like an even-handed approach.
Well done.
Dr. Paul van Minnen, thank you for joining This Medical Life.
Oh, it was a pleasure. Thanks for having me.
Dr. Sarah Shepherd is an anatomical pathologist who's trained at Flinders University, Peter MacCallum Cancer Centre in Melbourne, as well as the Royal National Orthopaedic Hospital in London. Dr. Shepherd specialised in bone and soft tissue pathology, including molecular correlation, and Sarah currently works at ClinPath in Adelaide and is our guest today on This Medical Life podcast. Sarah, welcome.
Thank you. Thank you, Steve, for that very kind introduction.
Oh, pleasure. I've got one curiosity. Do you two ever bump into each other in the lunchroom at ClinPath?
Yeah, walk past corridors, all the time.
Yes. I normally see Trav as he's about to go out for one of his lunchtime runs, usually.
Avoiding work, probably not the best thing.
Okay. All right. Well, let's get to the topic in hand, the prevalence of Dupuytren's contracture. How would you rate that, Sarah?
Well, to start with, I don't know how much of this you covered with Paul already, but Dupuytrens is actually just one of a group of proliferations that we call the fibromatoses. So Dupuytrens is the clinical term for what we designate in pathology world as a superficial or a palmar fibromatosis. So the fibromatoses are a broad group of benign fibroblastic proliferations, which all show a similar appearance when we view them under the microscope. So broadly speaking, they're either superficial or they're deep. Some of the other types are plantar fibromatosis that you can get in the foot, which is commonly called Lederhose disease. And then you can unfortunately get involvement of the penis or penile region, which is called Peyronie's. And then there are the other types that occur in deeper regions or in the soft tissue areas of the abdomen or pelvic cavity. So Dupuytrens is the most common of the fibromatoses, and it affects about 1 to 2% of the population. The prevalence increases with patients' age, and it's estimated that up to 20% of people at age 65 can suffer from the disease. Patients under 30, and in particular children, are almost never affected. There is a genetic susceptibility, and as I'm sure Trav has alluded to, it occurs more often in people of Caucasian and in particular Northern European ancestry. It's almost never seen in people of Asian or African descent.
Can I just ask a question here? I don't ever see this talked about in the news. Is it because I'm not looking for it and you do see it pop up from time to time? Because that's a high percentage of the population.
It is. It's a very, very common disease, but it's not life-threatening, let's put it that way. It's more of a sort of physical discomfort, or it can lead to some sort of difficulties using the hand. So it's probably much more common and just not spoken about terribly much.
Okay.
Can I ask, do we know the pathogenesis of the disease? Do we know the underlying pathogenesis of this?
Well, we do. So essentially, the superficial fibromatosis, or Dupuytrens, is a benign, so meaning a non-malignant proliferation of a type of cell called a fibroblast or a myofibroblast. And this is where the explanation can get a bit complicated for lay people, because the injury and trauma releases things called fibrogenic cytokines, or calling signals, I suppose, that activate the fibroblasts and the myofibroblasts, which form an extracellular matrix or a scaffold, I suppose. In people with diabetes, for example, it's thought that microvascular changes can lead to local hypoxia or lack of oxygen, and that might stimulate the fibroblastic proliferation. But there's still a lot of research going into the exact pathogenesis, but fibroblast growth factors and transforming growth factors have also been proposed as having a role in disease progression, but that, I think, might be a bit beyond the scope of this discussion.
So then, do we know the etiology? Why are the ring and the little finger pulled forward?
Well, although they're the two most commonly involved fingers, all the fingers can be involved, and unfortunately up to half of cases can be bilateral, so it can involve both of the hands. The onset of the disease is usually slow and insidious, and it does usually affect the fingers on the ulnar side, so that's the fifth and the fourth fingers first, but clinical progression doesn't invariably occur in all patients. So after the initial presentation of a firm lump or a nodule, you develop these cord-like indurations or bands, which are then accompanied by the flexion contractures, ultimately bending the fingers inwards.
So when you look down the microscope, what do you actually see?
Well, the appearance under the microscope actually depends on the age of the lesion. So in general, palmar fibromatosis goes through a progressive number of stages. So you get a proliferative sort of nodular phase with relatively very high cellularity early on, and that progresses to a more involutional or sort of scar-like stage. So the proliferative phase shows a crowded population of plump, immature-looking fibroblasts. They're sort of quite bland, spindly cells that form one or more nodules, and the individual little fibroblasts are quite uniform in their size and their shape. So the fibrous nodules basically originate in the palmar aponeurosis, and then they extend out into the overlying fat. Nodules that have been there a really, really long time, they show decreased proliferative activity and increased collagen deposition. So basically just like scarring essentially. And so the end stage under the microscope is much less cellular and densely sort of collagenous and resembling tendons.
Does any immunohistochemistry help sort this out when we're trying to work out what this lesion?
Not really is the short answer, because fibroblasts and myofibroblasts are involved in the process. There's often labelling for sort of relatively non-specific antibodies directed against smooth muscle actin or muscle-specific actin, but it doesn't really help with the diagnosis because lots of other normal and abnormal tissues also stain for those stains. We can see some labelling for a stain called beta-catenin, but it's not very reliable and it's more commonly seen in the deeper seated soft tissue lesions. But even then it's quite unreliable and I personally don't tend to perform it.
So if there's a strong genetic basis, is there any molecular tests that we can do to help confirm?
Also, again, no, not really. There was a collaborative group who performed analysis on a bunch of these lesions, and only 3 cases in total showed any cytogenetic aberration. So at the moment, no, there aren't any repetitive, reliable molecular studies that we can perform at this time.
And is there any common differential diagnosis of this lesion? Is there anything else this could be when we're looking at it?
Well, there aren't really a lot, if I'm being perfectly honest. Ordinary scar tissue can look pretty similar, as I mentioned before, but fibromatosis tends to be a bit less organised and more paucicellular. But if you look at scar tissue in the involuted phase of Dupuytrens, yes, they're pretty similar, practically identical. There is a nasty type of tumour called a fibrosarcoma that might potentially look a bit similar to some inexperienced players. It tends to be arranged in long sort of sweeping fascicles, but the individual cells appear much more atypical with lots of little proliferating mitoses, so it's turning over. And fibrosarcoma is extraordinarily rare in hands and feet, so it would be a very brave pathologist making that particular diagnosis.
And just finally on the lesion itself, are margins important in this lesion? Do we report on that at all?
No, we don't. I never comment on the surgical margins, and so far no surgeon has ever contacted me to find out. It doesn't really bear any outcome to the risk of local recurrence of the disease.
And just before we finish, Sarah, are there any things you'd like to say to GPs who are at the front line in noticing these things? Any pearls of wisdom or things they should bear in mind?
Well, I think it's the sort of disease that can progress and get worse over time. But I think the main thing is finding out how much trouble it's actually causing the patients. Because if it's not actually affecting their day-to-day lives, they may not necessarily require surgery, but it depends on how much it's affecting them. So having a good conversation with the patient, it might be something that they just mention in passing at a routine visit, and knowing when to refer on for surgical intervention when it starts affecting the way they live their day-to-day life. Excellent.
Dr. Sarah Shepherd, thank you for joining us here at This Medical Life.
Oh, you're very welcome. I'm sorry for the phone interruptions.
Well, that just shows that you're in demand.
I hope someone probably chasing me down for a report.
And Dr. Travis Brown, my final thought on this excursion into the realm of Dupuytrens is I feel like I've been on one of those big roller coasters. It travels so quickly, the different things we've skimmed across, up and down, lots of detail, including some areas where we don't know, but I love the pragmatic ending that Dr. Sarah was talking about there of using the litmus test. Is it impacting the client, the patient?
The amazing thing about this condition is that through history it's been seen as either a blessing or even a curse, and it would have been a debilitating illness that today is managed so simply. You can have day surgery and be back to doing exactly what you're doing which is in history, it could have been something, your livelihood could have been at stake. So it shows how far we have come in a space of a few hundred years to a disease that was debilitating potentially for thousands of years.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a Pathnotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.